eminent faculty members and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Joseph Maria Ribera from Barcelona, Spain, our chief guest for the day, Dr. Aditya Jandial from PGI Chandigarh, all discussants and participants to this virtual symposium on adult ALL, what are we doing in Spain? Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a senior hematologist and bone marrow transplant physician from Surat in Gujarat. Dr. Amit has many publications to his credit. I request, sir, to navigate this program further. Over to you, sir.
Thank you, Mr. Sumit. Well, very good morning to all of you, and good afternoon and good evening to all others who are joining from the rest part of the world. Today, our guest speaker for the day is no other than Dr. Joseph Maria Ribera from Barcelona, Spain. And he's going to lecture us on adult acute lymphoblastic leukemia. What are we doing in Spain? This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and very well managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan and Team Zydus, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Aditya Jandial from Chandigarh, our guest speaker for the day, Dr. Joseph Maria Ribera from Barcelona, Spain, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for sparing the Sunday morning, afternoon or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 26th of July 2025 from 7 p.m. Indian Standard Time and 8:30 a.m. Central Time, we have Dr. Saji Kumar from Mayo Clinic, Rochester, USA speaking to us on definition and management of high-risk myeloma. And the following day, that is Sunday, 27th of July 2025 from 11:30 a.m. Indian Standard Time and 7 a.m. Spanish Time, we have Dr. Maria from Spain speaking to us on myelodysplastic syndrome and update. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a discussions, look on all our discussions for the day. So these are our discussions for the day. And now it's time to introduce our guest speaker for the day. We have no other than Dr. Joseph Maria Ribera from Barcelona, Spain. Let me introduce Dr. Joseph Maria Ribera to all of you, and we know him very well. We have heard him many times on various webinars. He is a director of the stem cell transplantation unit at the Hospital Universitari Germans Tries I Pujol and head of the clinical hematology department for the Catalan Institute of Oncology, also at HUGTP. He joined the Joseph Carreras Institute at its creation and participated in the process of creation of the acute lymphoblastic leukemia research group. He is a professor of medicine at the Autonomous University of Barcelona. He teaches postgraduate courses at the UAB, University of Barcelona, the Universidad Internacional Menéndez y Pelayo, and the Escuela Nacional de Sanidad, as well as carrying out other varied teaching duties. His work and publications have made him well known internationally, and he is a member of the steering committee for the acute lymphoblastic leukemia of the European Leukemia Net and the European Working Group for Adult Acute Lymphoblastic Leukemia. His research focuses on the study of new treatment approaches and prognostic factors in adult ALL, and he collaborates closely with the lymphoma research group in the study of therapy and prognosis in HIV-related lymphomas. He has authored as well as co-authored more than 500 published clinical papers and 100 book chapters on hematology, oncology, and internal medicine. Today he is with us and is going to lecture us on adult acute lymphoblastic leukemia. What are we doing in Spain? But before he does that, let me introduce our special guest and the chief guest for the day. We have no other than Dr. Aditya Jandial from Chandigarh. We all know Dr. Aditya very well, but it's my formal duty to introduce Dr. Aditya. Dr. Aditya is MD DM Clinical Hematology from PJ Chandigarh. At present, Assistant Professor at the Department of Clinical Hematology and Medical Oncology at PGI Chandigarh. It's my privilege to welcome Dr. Aditya Jandial to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Aditya.
Good morning, everyone. Am I audible?
Yes, you're audible.
Yeah. So, first of all, thank you for the invitation, and it is my privilege and great honor to be part of this webinar organized by Mumbai Hematology Group under the visionary leadership of Dr. M.B. Agarwal sir. And I believe, and I strongly believe that no discussion on hematology education in India is complete without acknowledging the efforts of Dr. M.B. Agarwal, sir. So his relentless commitment and I would say his initiatives has empowered dozens, I would say hundreds of trainees, hematologists across the country and abroad as well. And it is like because of his efforts for over the last 40 years and more, that what we are seeing today is the strong and growing network of hematology in India. So, having said that, I also take this opportunity to reflect on some of the promises and challenges of hematology in India. So, we are a country of 1.5 billion people. There is a huge burden of benign and malignant hematologic disorders, and although there has been like great like advancement in the hematology care in last 2 or 3 decades, but we are still grappling with some of the challenges that we need to overcome to improve the overall outcomes. So we are dealing with delayed diagnosis and limitation in access to the care for hematologic disorders. So I think some of the important things that we can look forward to for improvement in hematology in India. So first of all, I think we need to improve our framework for early diagnosis of hematologic disorders, because what we generally see that patients present to centers of excellence or specialist centers late in the disease course, and that is one of the reasons why we are seeing, I would say, high early mortality as far as hematologic malignancies is concerned. We are discussing acute lymphoblastic leukemia today. Although we say that 90% of the patients are cured, especially children, for this disease, but reality is that the early mortality in, I would say, many of our centers in India is as high as 20%. So we need to strengthen early diagnosis, and we need to educate the primary care physicians and general physicians. And I think Mumbai Hematology Group is playing a great role in that regard. The second thing that we need to do is we need to innovate, and we need to adapt the recommendations or international guidelines as per to our own framework and as to our own, I would say, resources. So in that regard, I think we need to invoke the great Indian jugaad in that sense. We know that we launched Mangalyaan at a cost less than the Hollywood movie Infinity, and I think that is one of the benchmarks that we can look forward to. Now we have indigenous CAR T cell therapy available at a cost as low as 20 to 25 lakh rupees. So I think innovation need not to be expensive; it can be economical, and we need to collaborate with relevant players in this domain to come up with similar therapies. The last but not the least, I would say there is huge need to collaborate with within the country among the institutes, so that we can address research questions that are relevant to our to the treatment of Indian patients, and that the data that we are going to like analyze, I think the results are going to be practice informing for majority of the hematologists in the country. And obviously, I think we often quote the studies from the West, Europe, for most of our like research questions. I think we are a huge country. If we make concerted efforts in this direction, we'll have our own data, and that will be helpful in searching for solutions for our own problems. So thank you once again to MB Agarwal sir and Mumbai Hematology Group, and I look forward to the fruitful discussion. Thank you.
Thank you, Dr. Aditya, for your wonderful words of wisdom, and your thoughts are really provocative and very inspiring for all of us. Wonderful thoughts you have. Thank you so much, Dr. Aditya, for being our chief guest for the day. And now, Dr. Rivera, sir, screen is yours.
Okay, thank you. I'll share my presentation. Can you see?
Not yet, sir. Yes.
Okay.
Can you please do it in full screen mode? Yes, perfect, sir.
Okay, well, thank you to the Mumbai Hematology Group for having invited me again to present this, in this case, what we are doing in the Spanish PETEMA group. So these are my disclosures. Well, first of all, some words of what is the PETEMA group. The PETEMA group is the Spanish working group linked to the Spanish Society of Hematology and is focused on the therapy of malignant hematological diseases, especially ALL, AML, and multiple myeloma. So it has a bicephalic structure. There is a council of PETEMA that is responsible of the scientific part of the protocols and trials. And this is a PETEMA foundation that is responsible for the economical viability of the group and also has the capability, this is very important, of acting of promoter of clinical trials. This is a very important issue for our group. So this PETEMA is structured in several working groups: AML group, ALL group, monoclonal gammopathies group, myelodysplastic syndrome, CLL, marrow-aplasia, and even benign hematological diseases. This is our setting of work. Well, what has been occurred in recent times in the therapy of ALL? Really, it's clear that that has improved either for pH positive ALL or pH negative ALL, less for TALL. Well, for pH positive ALL, the introduction of ponatinib in first line has supposed a step ahead in the outcome of the disease. The incorporation of immunotherapy in first line also improved substantially the outcome of the patients. And for relapsed refractory ALL, CAR-T have the same efficacy as that of pH negative ALL. As a result of that, there is a reduction of the need for allogeneic stem cell transplantation in first complete remission. Regarding pH negative ALL, the most important issue has been the incorporation of blinatumomab in first line in consolidation combined with chemotherapy. Also, there are promises with menin inhibitors for KMT2A rearranged ALL. There are many trials in development combined with AML also. And also CAR-T for relapsed refractory ALL has improved the prognosis for this especially poor prognostic subgroup of patients. For TALL, not many advances. Perhaps the introduction of BCL2, BCLX inhibitors such venetoclax, navitoclax combined with chemotherapy, but the most promises come from the use of CAR-T for relapsed refractory ALL, because this is up to now the only promise rescue therapy for these patients. Well, this is my view on how to treat ALL. So first we have to split the B-cell precursor or TALL, and within the BCP ALL, we have to consider mature B, Burkitt type ALL. There is a specific chemotherapy combined with rituximab. For Ph positive ALL, we have attenuated the chemotherapy, combining with TKI, and then incorporating the immunotherapy as commented before. For Ph negative ALL, we have to separate, if possible, Ph-like or not Ph-like. For Ph-like ALL, the outcome, the standard therapy is chemotherapy and transplantation. Perhaps if we are fortunate and we can use directed therapy, targeted therapies, well, we can do it, but up to now, there are no solid results in this field. And for the remaining patients without Ph-like ALL, the standard therapy is chemotherapy, incorporating immunotherapy in consolidation, and follow it or not by allogeneic stem cell transplantation, depending on the risk of the patients. For TALL, I think it's important to separate the most immature form, the ETP ALL, that in fact is a mixed phenotype ALL many times. And in these cases, we are opting for a lymphoid and myeloid combined lymphoid myeloid chemotherapy, and then followed by allogeneic stem cell transplantation in all patients. And for the remaining patients, chemotherapy and transplantation, according to the risk of the patients, could be the treatment of choice. What are we doing in PETEMA? In PETEMA, we began our cooperative studies in 2019. I'm sorry, it's in 1989, sorry, and with our first protocol. And then we have done a chain of protocols that are linked, one in which one we are learning, one the next are learning from the results of the previous. And currently there are 4 trials for age-adapted and subtype-oriented therapy. One trial for ALL in young people, another for older patients, another specific for mature B-ALL, and another specific for Ph-positive ALL. We will see the results in the forthcoming slides. Well, let's begin with Ph-negative ALL. The first trial that changed our way of treating ALL was what is the high risk 11 trial, in which we used the flow MRD in order to decide what is the most appropriate post-induction therapy. Our survival is at 5 years was about half of the patients, and we can split a subgroup of patients in which had 60% survival, and these patients were not submitted to allogeneic transplant patients, despite having high risk ALL. And this was due because those patients who have a good MRD clearance post-induction, less than 1 to 10 to minus 3 at that time, and less to 10 to minus 4 after consolidation, these patients were not transplanted and had a promising overall survival. Well, and this represented an increase in the survival compared with our previous trial, in which we used the speed of cytological reduction, the the speed of blast reduction in induction as the criteria for successive therapy. So this was clear that the use of MRD as of a decision tool increased our outcome compared with previous trials. Well, what we see about we use a next generation flow that reaches a sensitivity of 2 to 10 to minus 6, very, very high sensitivity. And what we see? Well, from day 14, mid induction, we showed that there was a proportion of patients that were MRD negative at that time, and of course, this increased at the end of induction. 64% of the patients at the end of induction reached a MRD level less than 1 to 10 to minus 3, and this proportion increased to 91% after consolidation. Well, what we see in this study was that if the reduction of the MRD level was higher than 1 to 10 to minus 3, 1 to 10 to minus 4, those patients had a very promising outcome compared with the remaining patients. And this outcome even improved if this level, 1 to 10 to minus 4, was achieved by mid-induction. This patient had an excellent prognosis. Unfortunately, this is a very slow in number group, but if you have the chance or the fortune to have MRD clearance very early, you have the probability of having a good outcome. Well, in our just closed protocol, ALL 2019, we have a combined criteria for risk assessment. In our previous trial, we only used MRD. But in the current trial, recently closed, we combined the MRD level and the genetic criteria at baseline. And increased the MRD threshold in order to define the MRD response. So we increased 1 logarithm the level of MRD after induction in order to have to select the group. And those patients who did not achieve the MRD level less than 10 to minus 4 were considered as high risk. But we included a further step that we needed to have 1 to 10 to minus 5 level in order to define the risk. So those patients that even achieving a good MRD outcome after induction, but not achieving 1 to 10 to minus 5 level after consolidation were all considered, also considered high risk criteria. But then we combined this with genetic background in order to have a combined approach. So if patients have hypodiploidy, less than 40 chromosomes, and age over 35, KMT2A rearranged, TP53 deletion or mutation on hypozygosis, deletion of Icaros and CDKN2A and B in B-cell precursor ALL, and no mutation of Notch1 and or mutation of RAS-PTEN for TALL. Any of these criteria defined the patient of high risk. So the combination of this MRD criteria and genetic criteria defined the final risk, and patients with high risk were submitted to allogeneic stem cell transplantation early in CR1. Well, this study included patients, adult patients until 60 years, and those patients, and the most important thing is that all the studies were centralized. flow cytometry was centralized for diagnosis and for MRD assessment, and a FISH panel for pH-like ALL was included. The SNP array was done in all patients for B and for T ALL. A customized panels for B cell precursor ALL and T ALL were also done. And in recent years, optical genome mapping has been incorporated, but this has been incorporated a posteriori of the design of this study. Well, this is the overview. All patients with pH negative ALL received a prephase, and those patients who achieve an MRD after the first induction cycle and have a good MRD level clearance and have a good genetic risk proceeded to chemotherapy. After the first part of the consolidation was achieved, a next MRD assessment was done, and if they reduced one log the MRD level, those patients proceed to delayed consolidation and maintenance. A second group is the patients that begin very well but did not reach this second MRD threshold, and those patients received a delayed transplantation. The third group included those patients that need 2 cycles of inductions for achieving CR, or if they achieve CR with 1 cycle but have a poor genetic risk, they proceed to consolidation and then early allogeneic transplantation regardless of the MRD level. And finally, we we had a different approach for patients with early pre-T ALL, early T-cell precursor ALL, that were treated with FLAC-IDA for induction, and those patients, if achieve CR, independent of the MRD of the genetics, all patients received consolidation and transplantation. This is the overview of the protocol. We have now almost 600 valid patients, and according to the genetics, for B-cell precursor ALL, 64% had a standard risk ALL, and for T-ALL, only 34% achieved a standard genetic risk ALL. Well, this protocol was also applied for patients with lymphoblastic lymphoma, for mixed phenotype ALL or undifferentiated ALL, or even for patients who were older than 60 and fit according to the physician's decisions. But these patients will be analyzed separately in several studies. For the non-ETP ALL, that means all B-cell precursor ALL and all T-cells excluding the ETP ALL, we have selected a group of 400 patients that have valid data and have a sufficient follow-up in order to be included in the follow-up analysis. And in this series of patients, it's clear that patients with TALL were younger, had more white B cell precursor, white blood cell count, and it's as expected. This is not different, but the distribution of a standard risk and high risk was different, significantly different in T versus B cell precursor ALL. Regarding B-cell precursor ALL, 15% were pH-like, 11% KMT to a rearranged, 8% low hypodiploid, 6% high hyperdiploid, 5% T119, 5% PATR, and 4% CNF 384 rearranged level. And a minority of rearrangements were identified in this study. But there is still 1/3 of the patients that we could not identify the subtype according to the strategies used in our trial, and we are focusing on this in order to finding minority subgroups within this group. Okay, for TALL, the genetics for a standard risk was 80% and high risk 52%. Well, what is the response after induction? After induction, death was very low, 3% of the patients, and 84% of patients achieved morphologic complete response after first induction. And among them, there were a subgroup of patients that have good MRD clearance but poor genetics, or poor MRD clearance, and those patients were moved to the group of patients who were addressed to allogeneic stem cell transplantation. Well, at the end, after induction 1, 88%, but after induction 1 and induction 2, this complete response rises to 95%. And those patients after induction 1 had MRD level that 1 to 10 to -4, less than this in 63% of patients. If we increase the MRD level, half of the patients had after induction 1 an MRD level less than 1 to 10 to -5, and those patients who achieved complete response after induction 1 and induction 2 and had an MRD level of less than 1 to 10 to -4 was 91% and 67% if we increase it 1 log level. So we can see graphically those patients after induction 1, 63% of MRD negativity and 47% of MRD negativity at the level to 1 to 10 to -5. Well, at the end, we can allocate to chemotherapy or transplantation 40% of patients to chemotherapy, 61% to allogeneic stem cell transplantation. Well, our 3-year overall survival probability is 64%, and if we do this per protocol, so without any deviation, the figure is absolutely super impossible. The cumulative incidence of relapse at 3 years was 40%. Okay, no difference with adolescents and young adults and older adults were observed. The adolescent and young adults were those who had 18 to 40 years old, and also neither this difference were observed in the cumulative incidence of relapse. According to phenotype, no difference with B-cell precursor and TALL in order to the overall survival and the cumulative incidence of relapse. But it's important to see that in TALL patients, no relapses after 2 years have been observed. Well, when we see among the B-cell precursor ALL, according to the major subtypes, so those patients with common and pre-B ALL had a better outcome than those patients with more immature form of ALL. And the responsible of this, of course, is the relapse incidence. According to T-cell phenotype, cortical and mature TALL had the best outcome, followed by ETP, and the poorest is the pre-T subtype. That is the subtypes that had the high cumulative incidence of relapse. According to genetics in B-cell precursor ALL, we identified those patients with PAX5P8R and CNF384R these two subgroups had 100% survival, no relapses. It is very important. And the second most good sub-risk is high hyperdiploid ALL and T119. So these are, but we identified two new genetic subgroups with excellent prognosis that it was similar that has been described by other groups. Okay, so focusing on the PH-like ALL, of whom 90% were assigned to transplantation according to our genetic criteria, we can see that was expected. Most of them were of Jack class, minority were an Abelson class, and really up to now we have not observed a different prognosis of patients with PH-like with the remaining B-cell precursor ALL, neither for survival nor for cumulative incidence of relapse. What we observed is that among this PH-like subgroup, that those who showed an Icarus plus signature had a poor prognosis than those that who not this had this genetic signature. Well, this is for me is the most important slide. That is a clear example that the combination of morphological and molecular response and standard risk genetics. Any of these patients were transplanted. This subgroup of patients showed a very, very nice subgroup survival, and compared with the other subtypes, and especially for those patients who had only MRD criteria, but really no independent of the genetic criteria that had a poor prognosis. So that we identified clearly a subgroup, not very important, 109 patients that combining MRD and good genetic risk achieved a high good prognosis and less probability of survival. And focusing on this group, those patients that had good MRD, good early MRD clearance, absence of genetic criteria, high risk genetic criteria, and good MRD2 clearance of MRD, those patients who were absolutely treated without transplantation, really the probability of survival is 89% and only 19% of relapse probability after resigns. I say only, but I am worried because those patients that we have selected according to the MRD and genetics, so there is no other best way to select these patients, still had a proportion of relapses that this means that we have not absolutely refined the definition of the best group. And when we compared these characteristics from the remaining patients, just these patients were younger and have less frequency of hyperleukocytosis as expected. So and when we what were the genetic criteria of these patients, really we found that high hyperdiploid T119, PAX5, PATR, and DAX4. So there are good subgroups, but there are some groups PH-like and this that are not so good, but are still represented in these patients, and especially a B other subgroup that needs to be further subclassified. We may guess that within these patients that there are patients with poor genetic risk groups that are assessed to the good risk group because we do not have sufficient tools for identifying the genetic background of these patients. Regarding transplantation, we are proud that our transplant-related mortality is only 14%, and the problem of transplantation is the cumulative incidence of relapses. This is a fact. So even with improving the outcome of patients by having a good reduction of the toxicity, really the problem is the relapse after transplantation. There is a pending matter for patients who relapse after transplantation, because only a minority of them could be successfully rescued with salvage therapies. Well, we analyzed if the MRD level before transplantation had an impact on the cumulative incidence of relapse. In fact, almost all patients went to transplantation in a good MRD status, but up to now, even with the low number group of patients with MRD positive at the moment of transplantation, there is no difference in their cumulative incidence of relapse. Focusing on ETP-ALL, there is a minority subgroup, 23 patients in our study, 33 having the criteria for this analysis. Well, when we compare it with the remaining ETP patients, no significant differences were observed in the clinical parameters, but all patients with high risk, all patients with ETP-ALL had high risk genetic features as defined in our trial. Well, in those patients, the complete remission rate was 64%, and it was clear that we cannot be able to rescue any resistant patient. So when the disease is resistant, we have not found any salvage therapy for these patients. Well, at the end, the 3-year overall survival probability is 61%, and the cumulative incidence of relapse is 25%. Well, when we compare it, if we have improved with regards to our trial that only considered MRD compared to for our current trial that considered MRD and genetic background, we have shown that a slight but significant improvement has been done in the most recently trial. Well, to conclude from our trial that recently closed is that adults with Ph-negative ALL, the assignment of post-remission therapy based on the combination of MRD and genetic risk is feasible, and those patients who have a genetic risk among patients who have a good MRD clearance could be identified as a subgroup of patients with excellent prognosis, more than 80% of survival, without the need of transplantation, and this in way validates our strategy of integrating genetic risk and MRD, but we think that improves the precision of risk stratification in adult patients with Ph-negative ALL. What are we doing in the protocol that we will activate very, very soon? Well, we also, for this, we can separate B-cell precursor ALL and T-ALL because now there is blinatumomab used only for B-cell precursor ALL, of course. And really, those patients, we have done the same induction, prephase and induction 1, we have not changed it. And those patients who achieve a morphological complete response receive a cycle of blinatumomab, and if the patients have a good MRD level, 1 to 10 to -4, and absence of genetic risk, the same genetic risk as used in the protocol, in the preceding protocol, we continue combining a second cycle of blinatumomab, 2 cycles of chemo, 1 high-dose methotrexate, 1 high-dose aracé, blinatumomab, high-dose methotrexate, high-dose aracé, and blinatumomab. And then if we achieve a further log reduction of MRD, they proceed to maintenance therapy. If not, they proceed to delayed transplantation. Those patients that who did not achieve the good MRD level after induction one and had and or those which achieving a good risk but having a poor genetic background, they receive high dose methotrexate, another cycle of blinatumomab, and high dose RAC, and early allogeneic transplantation. What occurred was with patients that did not achieve the morphological response after induction one. They receive inotuzumab 2 cycles, and if they achieve complete response, they enter considered at high risk, and independent of the MRD and the genetics, all will proceed to early allogeneic transplantation. For patients with failure to induction 1 and induction 2 are excluded from the trial. Well, this is our study. The most important thing is that incorporates blinatumomab in consolidation, early in consolidation and during the consolidation, and we have reduced the number of cycles with high dose methotrexate and high dose RAC from 6 to 4. 6 in the former protocol and to 4 to this our current study. Well, what we are doing for Ph positive ALL? We completed a trial, a phase 2 trial with ponatinib, and we now have updated the results with a median follow-up of 4 years, and really the 4-year survival is 92%, and the 4-year event-free survival 66%. So really, this was in this trial, allogeneic transplantation was scheduled for all patients, was performed in most of them, and without a substantial rate of transplant-related mortality. And 2/3 of patients did not additional TKI need after allogeneic stem cell transplantation. When we compare it with our previous trial, in which imatinib and the same chemotherapy, the difference was really astonishing. And the only difference with these studies is that ponatinib use in the green one, imatinib use in the blue one. Well, we participated in the phase 3 global phase 3 trial in which was comparing ponatinib versus imatinib combined with low-dose chemotherapy, and that showed a significant increase in progression-free survival, but not in event-free survival, and had a significant reduction of the MRD level after induction in the ponatinib arm. This is the major aim of this study. Well, we have participated and we are really proud of having an extensive experience on the use of ponatinib. One trial, one own trial, and another multicenter trial in which we have had the privilege of being present. What are we doing now in our current trial? All patients begin with imatinib because ponatinib is not licensed for use in first line in Spain. In Spain and in other parts of the world. So we use imatinib combined with attenuated chemotherapy, vincristine and steroids. And if the patient achieves a complete molecular response after induction, proceed to the standard consolidation, attenuated consolidation with imatinib. They continued and included in this consolidation phase methotrexate and RAC. If the patient does not achieve a complete molecular response, we substitute imatinib by ponatinib and then proceed. So if the patient continues, achieves complete molecular response and is fit, we assess the genetic risk of the patient. Genetic risk means pH-like signature. if the patient has a pH-like signature, regardless if it is incomplete molecular response, the patient will proceed to allogeneic transplantation and followed by maintenance with imatinib or ponatinib according to the TKI that was receiving before allogeneic transplantation. If the patient is in complete molecular response but has not genetic risk, we skip the allogeneic transplantation and continue with maintenance with imatinib or ponatinib according to the TKI that was receiving the patient, and a further maintenance of imatinib or ponatinib for 5 years. This is in the first analysis in March of this year. There were 136 patients registered, 129 valid, and really, and we showed that 42% of pH positive ALL had a pH-like signature. So this is the first thing that we have seen, and up to now. The follow-up is really short, but there is a promising overall survival and event-free survival. But these curves only indicates for me that we can proceed with the schedule that we have chosen. I think that these figures will change over time, of course. Well, what are the clinical trials in progress of in development in the PETEMA group? We have participated in the phase 2 trial, phase 1 to 1B to trial with Obesel. It's a CD19 CAR-T. This study has been completed and published in New England Journal. Then we have also participated in the phase 2 trial of an academic CAR-T cell developed in Barcelona. And really, this paper is submitted for publication. We are participating in a CAR-T for T-ALL that have a CD1A positive phenotype. That means cortical T-ALL. This phase 1 study is first in human phase 1 trial is ongoing. We also participated in one CAR-T, new CAR-T RAPTA cell that is developing in ALL in non-Hodgkin lymphoma. The ALL cohort is currently closed. We are also participating in a trial for CAR-T, academic CAR-T for relapsed refractory Burkitt lymphoma or leukemia. We have also participated in a phase 1 trial combining blinatumomab and an inhibitor of the so in another inhibitor, a combination of two inhibitors, and really this trial was closed by a sponsor because no improvement was seen compared with blinatumomab alone. We have participated in the phase 2 trial with subcutaneous blinatumomab in relapsed refractory ALL. The results of this trial have been recently published in I think it's Lancet Hematology just 1 month ago. We also are participating in a trial with a phase 1/2 trial with a menin inhibitor in KMT2 rearranged ALL relapsed or refractory. We are participating in a recently openly trial with relapsed refractory T-ALL based on drug combinations based on ex vivo data. So we have we face the sample of the patients, again, the combination of drugs, and we select the most appropriate for in vitro for giving to the relapsed refractory patients. And we are also participating in a phase 2 trial combining glofitamab and rescue chemotherapy for Burkitt leukemia and lymphoma. And for newly diagnosed ALL, we are participating in the Golden Gate trial. It's a trial combining blinatumomab in first line for older patients with Ph negative ALL and compared intravenous blinatumomab with no blinatumomab. Combined in both cases with attenuated chemotherapy. We are participating in the next, expected to open it by the end of the year, a phase 3 trial academic from Europe comparing subcutaneous blinatumomab with intravenous blinatumomab. Also, we are participating in a phase 3 trial that will be opened soon that compares olverembatinib, that is a third generation TKI developed in China, compared with imatinib, both combined with attenuated chemotherapy. And we also will participate in another phase 3 trial that will combine blinatumomab, subcutaneous blinatumomab, also versus intravenous blinatumomab for elderly patients with Ph positive, Ph negative ALL, sorry. So another thing that we analyzed, and I am very proud to show these results, because we were interested to know if there were different outcomes in different regions of Spain according to the results of the patients treated in PETEMA trials. So, and the most important thing, and I am very, very happy with this, that we did not see any difference throughout Spain in the outcome of patients treated with ALL according to the PETEMA protocols. This validates our approach to make cooperative multi-center studies, and we can provide to the Spanish patients the same opportunities of outcome depending on the region on they were initially treated. Well, to summarize, this is a very summary that we have, what we have achieved recently. We began in our in Ph positive ALL, our first trial with imatinib, a significant improvement according to the patients treated without TKI. Then we used ponatinib, really a very clear increase in outcome. In Ph negative ALL, we have increased our results using an MRD oriented and recently a genetically also oriented trial. In pediatric trials, we have shown an increase using in pediatric trials in adolescents and young adults. In TALL, we have increased the outcome, just refining the chemotherapy because no other new drugs have included up to now. And for mature BALL, we have increased our results, just adding rituximab to the specific therapy for these patients, an increase about more than 25% in the outcome, just adding rituximab to our previous chemotherapy. Well, to conclude, the first and most important for me, the multi-center collaboration is feasible in Spain. Now we have a network of more than 80 centers that follow the protocols. We have a centralized work for diagnosis of ALL and MRD assessment, and it's feasible. It significated really a huge efforts, but really we have reached it. We have improved the results of our trials over time. We have able to participate in international trials for the new approved drugs, blinatumomab, inotuzumab, ponatinib, CAR-T. We have had the opportunity of participate in the development of these important drugs for ALL. We have a promising activity in clinical trials, and again, the outcome is uniform across Spain, ensuring that to continue with our multi-center collaboration. So these are the 87 now are 95, but now, at the time I did the slide were 87, that any region of Spain are participating in our trials, and we are of course proud of it. And we have a net of labs to make a centralized analysis. In these labs, they analyze the same sample. First, the sample is sent to Salamanca. They do this, and then the remaining sample it travels to these labs that make some parts of the analysis. At the end, in our center, may assess the final genetic risk, and then and we send to all centers of Spain in order to have an adequate assignment of post-remission therapy of the patients. Well, these are the members of the labs, many young people. This ensures a future for our protocols. And well, thank you for your attention. This is my center in I am working. This is the Josep Carreras Research Institute, where we do the genetic studies, part of the genetic studies of the PETEMA protocols, and this is Barcelona. Thank you for your attention.
Thank you so much, sir, for that wonderful lecture as always. Superb, fantastic, no words about it, sir. Thank you so much. And I now request all our discussants to please put the hand raise signs so that we can start our question answer session with Dr. Joseph Rivera, sir. Yes, Dr. Krishnathan Kannan, sir, your question, please.
Excellent talk. Really mind blowing. I have two questions. For ETP ALL, if they have achieved an ideal MRD, do you still advocate CR1 allogeneic transplant?
Yes. So in our experience, ETP-ALL has a poor prognosis. In previous study, we have shown it, and really up to now, there are not any drug that will change substantially the outcome of ETP-ALL, and for that reason, it's a high risk group, and then assign these patients to allogeneic transplantation, because we do not have any other option up to now.
So even if they have no matched donor, do you advocate an alternative donor transplant, like a haplotransplant for them?
Yes. So we all patients in Spain at diagnosis it's made an HLA typing, and in order to find a histocompatible donor or to activate a search for unrelated donor. But if we do not have, you have an indication for transplantation, and you do not have a sibling or an unrelated, a perfectly matched unrelated donor, we make an haplo. But haplo is our third option if we do not have a sibling or a perfectly matched unrelated donor.
Thank you. The other question is, you said you use new drugs for TALL. What are the new drugs? Is it venetoclax or nelarabine for TALL, and when do you use it?
Venetoclax is not licensed for using in Spain. We use as compassionate use in relapsed refractory patients, but we prefer to begin with the NECTAR trial. So nelarabine, etoposide, and Ara-C, and if they fail to the NECTAR, well, then we use venetoclax combined with vincristine and steroids. But is our third option, because in Spain is not licensed the use of venetoclax.
Do you use
in ALL, of course.
For TALL, you use nelarabine upfront or in the relapse situation?
In first relapse, yes, combine it with in the setting of the Nectar trial, not as a single drug.
Thank you. Thank you so much.
Thank you, Dr. Kannan. Dr. Satish Kumar, your question, please.
Thank you, Dr. Ribeiro, for that wonderful talk. I have a 61-year-old, not very fit, Philadelphia positive ALL patient. We gave induction with dasatinib, steroid, vincristine, and couple of intrathecal methotrexate. He has not achieved MRD positivity. I mean, even by flow, it's almost 1%. So I've started on ponatinib. I have counseled them for blinatumomab, but I don't see blina in your algorithm. You have written who have not achieved complete molecular remission, CMR. You have started ponatinib, methotrexate, and RAC. So just wanted to know your views on that, Dr. Ribeiro. People who have not achieved remission after induction.
Yeah, the only option is to proceed to allogeneic stem cell transplantation, and then with maintenance therapy, perhaps with ponatinib if he tolerates it.
Unfortunately, he's not fit for transplant. So should
Yeah.
we give blinatumomab or high dose
Wow.
methotrexate?
No, blinatumomab. Blinatumomab clearly.
Thank you, Dr. Rivera. What about rituximab? Do you give rituximab in Ph negative ALL routinely?
It's a counseling. It's just a recommendation in our trial because rituximab is not licensed with for this, and really we recommended it. But what we saw in clinical practice, because we tried to analyze this, that any physician does what he wants or she wants. So there is no, we recommend a fixed use, but they do many possibilities. So it has been impossible to analyze in our setting, unfortunately.
Right, Dr. Rivera. PH like ALL, few patients did very well. Which are the subgroup of PH like ALL who did very well, who responded very well to the chemotherapy?
Well, we use chemotherapy and transplantation for these patients, and to our surprise, they are going up to now with the current follow-up. They are not going different from the remaining B-cell precursor ALL. We didn't expect this, but this is our reality. I don't know the reason.
That's good to know. Thank you, Dr. Rivera. Thank you.
There are other experiences in the world that comparing those patients, PH like ALL, that are all submitted to transplantation, with the remaining patients that are submitted according to the risk. And the experience is identical as ours. So those patients with PH-ALL that could reach transplantation have not a bad outcome. The problem is reaching the transplantation, I think.
So do you add JAK2 inhibitor or BCR-ABL inhibitor along if the JAK is positive?
No, unfortunately we do not have the opportunity of use any TKI inhibitor in PH like ALL in Spain. It's a pity.
Thank you, sir.
Thank you, Dr. Satish Kumar. Just on the same note, what Dr. Satish Kumar asked, which subgroup of the patients of PH like did extremely well with chemotherapy? And second thing, could you avoid transplant in any subgroup of patients with PH like ALL? That is what Dr. Satish Kumar's question was actually.
I think that PH like ALL, first of all, is a group of diseases. It's not a disease. So this is very important. No? The second thing is, I think, the genetic background within PH like ALL. So, at least in our experience, the outcome of patients of PH ALL without PH like signature, they do extremely well. The problem is that this is an infrequent issue. But those patients having a PH-like phenotype and not having Icarus plus, an Icarus plus signature, I think that there is no difference. That there is not a bad risk group. I think that PH like ALL is a generic name, a subgroup of different diseases.
Very heterogeneous group.
Yes.
Thank you. Yeah. Thank you, Dr. Satish. Dr. Ashok Meshram, your question, please.
Thank you, Dr. Ribeiro, for a good lecture. My question is regarding one patient. He is 22-year-old and he is B cell ALL pH negative. So end of induction is bone marrow is not in morphological remission. Subsequently received a salvage therapy, but still MRD positive. My question is the MRD showing 5% of cells CD22 expression. So my question is, how much percentage of cells used to be positive for addition of a inotuzumab?
If the percentage is high to 5%, because
5%.
we follow the definition of a standard definition of complete remission that means less than 5%. But if the patients have 5% or higher, we can use inotuzumab. If not, we cannot use because inotuzumab is not licensed for patients who are not refractory ALL, at least in Spain.
Thank you very much.
Thank you, Dr. Ashok. Dr. Geeta, question, please.
Thank you, sir, for that excellent presentation. Sir, I want to discuss a clinical case. This is regarding a 13-year-old boy with T-cell ALL with expression of myeloid markers. He had FLT3 positivity with a VAF of 17%. And at presentation, the counts was 1 lakh. He had a poor response to prednisolone. Even after 8 days of prednisolone, the count was still 1 lakh. But he achieved an MRD negative status of less than 0.01 after first induction. So how to proceed, sir? Because of his, now he is MRD negative after first induction. In this case with FLT3 positivity, whether we should use an inhibitor for FLT3, is he a transplant candidate? So I want to know this, sir.
Well, I have Amit help me because parts I have do not understood. This is a patient, with a young patient with ALL with myeloid markers.
Yes, sir.
And what occurred in the induction?
So actually, it's a young patient, young male patient, T plus myeloid, markers positive, FLT3 ITD positive. On day 8 with steroids, there was no decrease in the WBC count. The initial WBC count was 1 lakh, but at the end of induction, the patient was MRD negative to the level of less than 0.01%. Should we add any FLT3 inhibitor to such case, or how would you approach such cases, sir?
No, it depends of the type of myeloid marker, because if the myeloid markers are CD33 or CD15 the prognosis is the same of that of ALL without myeloid markers. Another thing is if the myeloid marker is genetic myeloid marker, for example, FLT3. If the patients express FLT3, it's worth to add FLT3 inhibitors. But if the patient shows only myeloid surface myeloid markers, the prognosis is the same, and we have to proceed according as any patient with ALL without myeloid markers. I think this is a different concept.
Thank you, sir. Any other question, Dr. Geeta?
Sir, thank you, sir. So I wanted to know, apart from the ETP ALL and the TALL with MRD positivity after induction, any other subgroup will you consider for transplant in T-cell ALL?
So apart from ETP ALL, any other subgroup of TALL would you like to consider for?
Yes. Those patients with TALL that do not have Notch1 mutation and have a RAS-PTEN mutation are submitted to allogeneic transplantation. And another indication is a lack of MRD a lack of good MRD clearance after induction, of course. And there are a substantial proportion of patients that non-ATP ALL that we still transplant. Yes.
Thank you, sir. Sir, one more question can I ask?
Yes, yes, please
Sir,
go ahead.
Sir, do you transplant all BALL with hypodiploidy?
No, no, no. Hyper or hypo?
Hypo.
Oh, yeah. Well, if there is a low hypodiploid ALL and older than 35 years, because we have a previous study that those patients who are young ALL and low hypodiploid have the same outcome of the remaining patients. But when we increase the age, the prognosis is really different. So we combine two things, age and low hypodiploid to define transplantation. And of course, poor MRD clearance that usually occurs.
Thank you, sir.
Thank you, Dr. Hita. Dr. Krishnan Karan, your question, please.
Yes, sir. The last question I have is for elderly ALL, how do you manage the same protocol or there is an age cutoff, and what do you do above 60 elderly ALL?
Elderly ALL. Well, we are now making a protocol for elderly ALL, and it's basically will be the same as young ALL, the same criteria, but we will use attenuated chemotherapy. For example, we will not use PEC asparaginase in induction in order to avoid mortality and important toxicities, and we introduce PEC asparaginase in consolidation, but we will attenuate the chemotherapy in all the phases, in induction and in consolidation, in order to not to lose patients for extreme toxicity. But we will include blinatumomab in consolidation in our new approach.
Can you use inotuzumab?
We don't use inotuzumab, just we use only for refractory patients at the end of induction. In first line, of course, if the patient relapse, we can use inotuzumab. But really, in first line, we can only use by criteria, because in Spain this is not allowed to use, only for refractory patients in first line.
Thank you. Thank you so much.
Thank you, Dr. Karan. So there are a few questions from the audience. Dr. Yimon Tent wants to know what is the preference and the difference between subcutaneous versus IV blinatumomab.
Subcutaneous on IV blina.
Blina, yes, sir.
Yeah. We for assistential reasons, we can only use intravenous blinatumomab. But we have experience in subcutaneous blinatumomab in the phase 2 trial, and our experience is extremely positive. So all the patients in refractory and relapsed ALL entered in MRD negative status, all of them, and the only thing that we have to be aware is the toxicity. So subcutaneous blinatumomab is more toxic than intravenous, especially for cytokine release syndrome. And for that reason, we give subcutaneous blinatumomab early in the morning, because in the evening the patient begins the CRS in the evening of the first day. This is very important. So and this is being seen in 70 to 80% of patients. It's clear that we use an extremely effective drug, but has a toxicity profile that it needs experience of managing this drug. It's not equivalent to intravenous blinatumomab.
Thank you, sir. And another question he has is BALL relapsed during hypersevered after phase 3A, that is the third cycle, 3A cycle. So what should be the dose and schedule of inotuzumab, and whether can we use blinatumomab before allogeneic stem cell transplant or CAR T cell therapy?
Well, it depends if you have an availability of clinical trial, of course. For me, the most attractive option is to include in a CAR-T program. So it is refractory, and then you can use CAR-T for reasons of high probability of achieve complete remission and low toxicity. Well, if you cannot do this, it depends on the toxicity seen in the previous hypercivat cycles. If the patient has developed hepatic toxicity, I prefer Blina. If the patient has not developed toxicity, I prefer inotuzumab because the probability of achieving a response for me it's higher than with blinatumomab. And then, of course, allogeneic stem cell transplantation.
Thank you, sir. Another question is from Dr. Shyam. Do you think vena consolidation should be incorporated as a standard of care for all the patients?
I think so. I think so. And my expectation is that will substitute chemotherapy elements, not replace, but substitute. Now the indication is generic, is combined, but the only experience, the only published experience is adding to consolidation chemotherapy. But my guess is to substitute part of the consolidation, having the same or even better results, and having low toxicity. This is my expectation.
Thank you, sir. And this will change the MRD-based approach?
The MRD approach?
Yes.
No, because we have established a solid network and a solid procedure of MRD assessment, and it works very well. So, and the next generation MRD is sufficiently sensitive for our purposes. So, next generation, that is the top, no, release is very expensive. We have not licenses in Spain, so and it is very difficult to proceed in a multi-center setting. So for all that reasons, we cannot do next generation, and we are following the flow because it works very well. It's feasible. It's feasible and it's quick and relatively cheap.
Thank you. So you mean to say that next generation flow MRD will overcome the genetic-based approach?
Sorry?
Next generation flow MRD.
Yes, yes.
Genetic-based approach?
Oh, yes. Yeah, we will combine. We will combine both. The problem is that there is an overlap. MRD overlaps with genetics. So, and in our trial, we consider separately. But I think this is not the truth. But I do not have, I do not know how overlapping this and establishing an overlapping criteria. It's very difficult for us.
Thank you, sir. Another question is from Dr. Sutan Thira Kanan. What do you think is the reason for getting a very good outcome with upfront ponatinib in Ph positive ALL?
Yes, ponatinib really it's powerful. Really, it is easily, it could be easily combined with attenuated chemotherapy and provides good MRD clearance and allows to further proceed with allogeneic stem cell transplantation or not. And there are experiences that it's feasible to combine with blinatumomab. So I think that ponatinib has a lot of reasons to be the first TKI of choice.
Thank you, sir. Another question he has that if the patient has got CDKN2A mutation positive, at diagnosis.
Yes.
Does ponatinib is superior in such cases?
Ponatinib?
Does ponatinib work very well in patients with CDK?
Yeah. I think that CDKN2AB as an isolate rearrangement, it means nothing. It should be combined with Icaros, etc., in order to define the Icaros plus signature.
Perfect. Thank you so much, sir. Dr. Divya Manohar, your question, please.
Good morning, sir. That was a very promising talk on ALL. Very happy to hear that. And I have two doubts, sir. In mixed phenotype acute leukemia, B myeloid types, what are the protocols that are available? Like, how do you choose protocol based upon whether the population of B or myeloid, or is it common for both the cases? And if the disease doesn't respond with the lymphoblastic leukemia protocol, how do you switch protocols?
Amit?
Her question is, in a patients who have B lymphoid, B lymphoid myeloid mixed phenotypic leukemia, so how do you approach B lymphoid and myeloid? Number one.
Yeah.
Patient does do very well with ALL based approach. Then what would be your next best therapy?
We have our first approach is a lymphoid phenotype, a lymphoid therapy, sorry, a lymphoid type therapy, followed mandatorily with by allogeneic transplantation, regardless of MRD, no problem. If the patient is resistant, well, we will try to change to myeloid type therapy, but I think that it has not if the patient is truly resistant to a lymphoid type therapy, it's difficult to be rescued with a myeloid type chemotherapy. What is important to think is to make a genetic approach, because if they have FLT3 inhibitor, FLT3 or IDH1, we have to combine with the lymphoid type therapy, FLT3 inhibitors or IDH1 inhibitors in order to potentiate the activity of the therapy. But really, they are difficult to treat.
So, is there any role for blinatumomab or inotuzumab, like if the patient is responding but not MRD negative, but then that time as a bridge for transplant, can we use blinatumomab or inotuzumab?
So if the patient responded very well to the lymphoid-based approach, ALL-based approach, but remains MRD positive, can we go for blina or INO before transplant?
Yeah, in this case, I think that is very difficult to put the patient in MRD negative status, and I will proceed to allogeneic transplantation, even in MRD positive status.
Okay, sir. So my another doubt is leukemia-related myelofibrosis. So we see myelofibrosis along with leukemia, and sometimes myelofibrosis per se can progress to leukemia. So when a patient presents with a leukemia with in bone marrow biopsy, there is fibrosis, like marrow is dry, tap is there. That time, how do we diagnose whether we take it as leukemia with myelofibrosis and proceed with leukemia therapy, or we take it as secondary leukemia after a myelofibrosis?
Yeah, this is a possible situation, but really, you will diagnose the leukemia in any part, and if for the diagnosis of leukemia, if we cannot achieve bone marrow blast, that there will be marrow blast in peripheral blood. If not, you cannot diagnose a leukemia. So I think that in these cases you have to make the study on peripheral blood. It's clear. Forget the bone marrow, and use peripheral blood for diagnosis.
Does the treatment change?
Sorry? The treatment doesn't change. No. The treatment has no changes. And the prognosis is not different. No, it's not different. This is myelofibrosis related to leukemia. Another thing is a blast crisis of idiopathic myelofibrosis. This is another thing.
Yes,
And
sir.
this is a very difficult to treat leukemia. But if there is a marrow fibrosis in the context of de novo acute leukemia, the prognosis is the same.
Okay. Okay, sir. Thank you so much.
Thank you, Dr. Divya. Another question is from Dr. Hitha B. In a patient who has got isolated CNS relapse, bone marrow is MRD negative. Apart from triple IT, when to incorporate allogenic stem cell transplant?
Our experience is that CNS relapse in ALL, either if it's isolated, has the same poor prognosis of marrow relapse ALL. This is our experience. So we have to clear the CNS, treat the systemic disease, even if you are not able to find, and then proceed to allogeneic transplantation.
Thank you, sir. Another question is from Dr. Hitha B. Patient with T cell ALL with HLH. Do we give T cell ALL chemo protocol alone, or should we incorporate drugs for HLH like etoposide or cyclosporine?
Difficult question because I don't have personal experience in this situation, but if there is HLH, perhaps I could use anakinra or another rather than etoposide. I think that etoposide is not a good drug for HLH. It's really a drug that we can use as when we are desperate, because I think that we can use anakinra or other biologic therapies.
Thank you, sir. Another question he has is, when will you incorporate FLT3 inhibitors in patients with ALL with FLT3 positive ALL? In your ALL?
Is ALL with a FLT3 positive?
Positive, yes.
Really, in this case, this is really a situation unusual, except if it is a mixed phenotype ALL. But there are no experiences. There are single cases, single case reports that the combination of ALL type therapy and FLT3 inhibitors is feasible. And of course, as single cases and as published single cases, the outcome is good. But I don't know any series of patients that have treated these patients. Just single case reports, and there is a bias, of course, a bias of publication. I don't have any doubt.
Thank you, sir. Another question is from Dr. Shyam. In a case of pH positive ALL, will PONA plus BINA based therapy overcome allo stem cell transplant for all pH positive ALL?
No. Really, we can skip allogeneic transplantation in a significant proportion of patients with pH positive ALL under PONA and BLINA. The problem is the genetic high risk group of pH positive ALL. That means those patients who are pH positive and Icarus plus. I don't know, I am not sure that ponablina is sufficient to eradicate the disease, or if they still need allogeneic transplantation, even if they are in complete molecular response. In our experience, we transplant these patients. I don't know what will we do in the near future.
Thank you so much, sir. Any other discussion? Want to ask any other question? Because I've finished all the questions from the chat box. Yes. So in that
Okay.
case, no more hand raised signs. Thank you so much for the wonderful update, wonderful discussion. Always a good learning from you, sir. Fantastic lecture, fabulous lecture, superb lecture. No words about it for you, sir. Thank you so
Okay.
much.
Okay,
And now,
thank you, and really have a good day, and thank you again for the kind invitation.
thank you, sir.
Okay.
And I now ask Mr. Sumit Kumar Madan from Intas to go for from Zydus to go for final vote of thanks.
Yeah. Thank you, Dr. Rivera, for sparing your valuable time. It was a very lucid presentation, and we have many key takeaways from it. Your session was followed by a very, very engaging discussion, sir. And on behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.B. Agarwal, sir, for providing us this wonderful opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Aditya Jandial, all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating this entire program webinar in a highly proficient manner. Last but not the least, this series of webinar is possible only because of continuous support from Perfect Square team. So thank you to them. Thank you so much, everybody. Have a wonderful Sunday.
Thank you. Thank you
Bye.
so much.
Bye.
Of you.